Very good evening. So I'm guessing while the crowd still collects, we are going to start our course to be right on time. The course is called Micro Innovations, Macro Impact. In today's date and time, when there is so much of heavy technology being pushed in by industry and these high-tech leaps and these newer lasers that are coming in, it's often these creative, small individual breakthroughs that actually make a difference in the patient outcomes and surgical skills. And I think we have a really good faculty to explain to us and to show us their skills and what all they've created over these years of innovation. And innovation is something that always gives a little mental buzz to whoever is in that category of people who think laterally. I want to start this session with Dr. Neeraj Israni's talk because I've listened to him a couple of times and I've always been excited to see what all he's making. So Neeraj, the stage is yours.
So, thank you, Dr. Samresh. I think when Samresh sir called me and asked me to present something, I wanted to do something offbeat and something that is different than usual. So we've been working on this since almost slide please. We have been working this on the last 6 months now, and we have actually done a good amount of research to call it the world's first Bluetooth compliance monitoring adapter for eye drops. There are similar ones, but the ones that we are making with the features, I don't think anybody is doing so. So this is my dear friend Rajesh, who is in the US, and he's always worried about his grandfather because his grandfather has glaucoma, and he always keeps thinking if his grandfather has instilled anti-glaucoma drops or not. And because of the time difference, it's an issue for him to remind his grandfather, and he actually came to me and told me, is there a way or is there some clue which will help him remember that I can, and even I can come to know that he's instilled an eye drop. That's where we had the research question, if there is a potential role of Bluetooth technology being attached to your eye drop and connected to your mobile phone to give you timely reminders for eye drops. So yes, we made the first eye drop compliance monitoring adapter, and the need for this is basically because of non-compliance, but also because of a lot of confusion that how many times have we put the drops, have we forgotten to put the drops, and with aging also hand-eye coordination is an issue. So we had an aim which I've already spoken about. Let's come to the first prototype. So as you can see, this was our first prototype, and it's basically a small adapter for your eye drop, whether it is a 5 ml or a 10 ml adapter, eye drop. And as you can see in the video over here, it has a battery system, and it's a lithium battery. So whenever you charge it for say around 3 hours, it will last long for 20 days. It has a microprocessor unit with a USB-C port, something like a gyroscope, which is an inertia control mechanism, and a pressure or a squeeze sensor. So this is how it basically now looks like. One sec. Can I have this video played, please? Yeah. So this is how it actually looks like now. All you have to do is just switch on the button, and you have to just clip the eye drop. As you can see, it has a USB-C pin, and you can just charge it like any other device. You have to just clip in your eye drop and open the knob of the drop. And this is the first prototype, so we're still working on, we have the second prototype, which I'm going to present after this. And this is a normal eyedropper, which we got from Amazon for around 300 rupees to make sure that the drop actually falls in the eye. Whenever you switch it on, whenever you squeeze this, what it does is that it will get connected to your mobile phone, which I'll show later. And it can document the number of drops that are instilled, not only the number of drops, but even at the particular time at which it was instilled. As you can see, it will show you that one drop is instilled at 21:45. So this is the second model that we've now made. Again, this looks a little bulky, but it's 3D printed. And you have to just clip in your drop. And what we now did was we attached the hinge-like mechanism for everting the lower lid. So as you can see, what he is doing is this is a patient and he is just squeezing, and you can actually see that the drop has also fallen into the patient's eye. So with one single squeeze and averting the lower lid, it is going to ensure that the drop is going to fall in the lower canthus of the conjunctiva. So the first issue that it's solving is compliance. How is it solving? Whenever it is going to remind the patient has to, the alarm is not going to go off. How much ever you try to stop the alarm, till you actually squeeze the drop into the patient's eye, or the patient does it himself. Only once this is done via Bluetooth, the alarm will go off. And this works two ways, so even the patient and the relative can come to know that the patient has instilled the drop. This is the mobile application that we're still working on. We've added many drops now. Let's take Alphagon P. You can pre-decide whether you want to put it in the right eye or the left eye. You can pre-decide the number of times, how many days, exact number of times you have to put the drop. So at that particular time, it will give you frequent alarms. And also there are different ringtones to identify different drops. So basically it's going to help in compliance. Now, a lot of people also suffer with drop wastage because these drops are expensive. For a patient, a 600 rupees drop, should last a month. So we added this small valve, which is battery operated. It's a micro solenoid valve. All this work is done by my team of IIT engineers. Now this is going to make sure that only and only one drop enters the patient's eye, not more than one. So how did this help us? When we did a small study, we saw that in the study group, whenever we gave the patients this sleeve or the adapter, the drop actually lasted for the time that it's supposed to last. Because in the other patients, the drop either ended up to be getting over earlier or later. Now, this is very interesting. This is how to make sure that the drop falls inside the patient's eye. So we did this thorough experiment using infrared sensors. Just see the video now. Whenever the patient is closing the eye and opening the eye, you see the difference? As soon as he's opening the eye, the red light blinks. That means what it basically is doing is differentiating between the skin and the conjunctiva. Now, this is on the big mechanism of reflectivity. So skin is relatively opaque and the conjunctiva obviously has a tear film. So basically, skin acts like a low scattered infrared light and conjunctiva has a higher return of infrared light. So we've again color coded the LED. Just to show a small video, once you switch on the button, I am using my finger to point the infrared lights. And as soon as I point the infrared, because it's skin, so it's going to start blinking green color. When it's conjunctiva, it's going to start blinking red color. So when the patient is squeezing the drop, he's going to come to know red color aa gaya hai, now I can squeeze. So this is how it's going to help not only in compliance, but also it's going to be a big boon for our patients as well as a surgeon, and it's going to prevent the progression in not only glaucoma, but even cataract and dry eyes. Thank you so much. His Highness has collaborated with us, and what they've done is, they're funding this project. Thanks to Dr. Rohit Shetty, sir, because he made me introduce them. So this is in the last stage. Now this prototype, now what we're doing is, there is an IIT plus MIT graduate who's helping us in making this. So very soon, probably in the next few months, what we also want to do is provide this free of cost along with the His Highness drop, because we have a MOU with them, and probably charge a 99 rupee subscription for the application to the patients. That's the plan so far, hopefully. Thank you. Thank you so much.
Plug kar denge. Nivin, is yours loaded? You can start while I plug in mine.
So thank you. So I'm Dr. Nivian. So I'm just going to share my journey of the CMT Flex IOL. So the first half is just going to be I think they have to switch the screen. about how the whole idea started and how the birth of the T-Flex happened. So as you all know that everything began with an idea, so that's how my idea started in 2017. So the basic concept was we are modifying different techniques for aphakic management using the existing IOLs that we have. So why not have a design that is specifically designed for aphakia? So that led to the birth of the T-shaped optic. So not only an idea is enough, but as you had already heard, Neeraj, you need a good solid partnering organization. So that's when we actually partnered with Apasami Associates, considering their 40 years of history. So basically you need a good teamwork to bring any innovation into the clinical practice. So our mission was very clear, to make it life easy for the surgeons, and at the end of the day the patient's vision should be better than what it is right now. So this was the first prototype that was there in 2018, slightly bulkier. So after doing that is what we learnt as ophthalmologists, what are the other barriers that are there as far as when it comes to getting a product into the system. So you need to have licenses, ethical clearance. So these things we are not taught about. So we'll have to do the entire reading, the paperwork that goes behind everything that is done, the regulatory approval, the ethics clearance, and the clinical trial. So yes, after 2 years of all this, we finally got the patent done. So and officially, yes, we had to launch it in our very own TNOA that was in Salem that we had launched it. So this was the launch. We have the volume slightly. So once the launch was done, I was very excited and happy. So and then subsequently in the couple of months, we launched it in All India Delhi. So that's when the product was about to go into practice. But then thanks to COVID, so everything came to a standstill even before it started kicking off and the surgeons could actually try it. So, but that also taught us so many lessons during that COVID time. So I know we cannot change the situation, but then we are challenged to change ourselves. So then what we started doing is we started modifying the designs so to make it easier. So a lot of questions asked, so thought why not answer these questions. So we also came up with the kit. So it's not only the IOL, but also specialized instruments that come along with that, the CMT Flex kit, to make it easier. So once that was done, the people started using it, and then we needed to get their feedbacks. So it is not about you alone and what you do and talk about. It is best when it is shared with others and when they experience it, and then they give you the feedbacks. And one very strong thing that I was taught and believed in is publications. Yes, there was the old saying called publish or perish, but that is the old saying, but the new saying is publish and flourish. So that's the whole thing. It is basically to share your ideas. And in this journey, actually, I learned a lot from other people as well. So coming to the case, actually, you can see this is a case of a aphakic patient that was planned for the CMT Flex IOL. So for, as any secondary IOL, the 0-180 degree marking is the key because that's where the lens is going to sit. So we make a 2 by 2.5 millimeters partial thickness scleral flaps. And then 1.5 millimeters away from the limbus, we make a 23 gauge sclerostomy. See, the other advantage of this lens is since it's a foldable lens, it can go through a clear corneal incision, a regular 2.8 millimeter clear corneal incision. And you can see as soon as the lens is injected, you just grab the head of it. Since it's a single piece lens, don't pull it out right now. See, that was one of the common mistakes that people were doing actually. So that's when it can tear or break. Just release the lens from the cartridge, leave the trailing haptic at the section or over the iris, and then start pulling out. So once you pull, you can see the pop of the T and it opens up. Now here again, because of the special designs of the T, it actually sits there, and so there is no need for tucking or suturing of this IOL. As you can see, a short animation clip that we had done. As soon as you pull it out, the T sits under the flap. For the second side, yes, we use the handshake technique. As you can see, you can hold the neck of the IOL, or some people have told me they use those dialing holes that are there. They use the Sinski and then retract it, and then they helped it exchange to the other side. So once it is done, it just sits, as I said, the 0-180 degree is going to be the key. There is no going to be tilt. So it is not defined by how much you tuck in or say, it's just going to stay there. And yes, you can go vertical. So depending on where your incisions are, you can change. So these are all our initial studies that we did, OCT over the sclera and the UBM. I think we needed to have a strong follow-up because that is what is going to say how the lens was doing. As I said, it is not about the lens and not about the invention. This talk was basically to encourage people from the journey. So these are a few people that actually helped me in my journey. I think even now Venkatesh sir is here from my first launch. He just walked inside, so thank you, sir. So after listening to my first talk, actually he gave me the confidence that it could go a long way. But then he told me what are the questions you have to answer. So he was the one who even said that you should do OCT over the sclera. I was thinking, why OCT over the sclera? He said long term people might ask you about erosions and how safe it is and exposure. So that's when, and then Suven sir, all the breakfast sessions that I've had with him, he's done the patent all himself for BX, so he gave me guidance on how important patent was. But then I couldn't do it on my own, so as I said, you can either do it on your own or you partner with somebody that you can do it with. How to derive at A constant? Yes, I was not very good at studies or this thing, so I needed somebody else's help. How to come to an A constant to a lens? What is an A constant of a lens? So it's all the questions that was fired at me at various conferences that led me to do better and make it and come up to the current status of what the product is today. So these are all the people who not only fired the questions but also helped me and guided me. In the end of the day, I think the volume they've cut it out. Then the actual result comes out when people start using it and give the feedback. So these were some of the surgeons who actually initially did it. This is Dr. Madanagopal from Salem, who was a VR surgeon. Can you play the voice? Do they have the voice?
Innovation, and we thank you for making our lives simple.
So this is basically.
Hello, I'm Dr. Bikramjit Pal from Ranchi, a retina surgeon.
So why this? Because
I have
you
been
get their
using CMT
perspectives.
flex lenses for the last couple of months, and I've performed 30 odd cases. So in today's scenario, amongst all different methods of scleral fixated lenses, I have gradually transcended to use for its excellent innovation and wish him all the best.
So sometimes you get positive feedback, sometimes you get negative feedbacks, but I think you should take both. And then lastly, again, just showing a small case. It's not only for the posterior segment surgeons. These are some modifications at what this particular surgical video is going to show you, that what all I learned from everybody else. So this can be done through anterior segment surgeons also. You can use the AC trocar maintainer. That was an invention by Dr. Amar Agarwal. So this was a dislocated single piece lens post cataract surgery. So we planned for the explantation of this lens with a CMT flex lens. So you can see here using the trocar, just make sure you don't hit the iris. So once you have the trocar as for the infusion, because for any vitrectomy or any secondary IOL procedure, hypotony is the biggest challenge. So as long as the anterior chamber is maintained, it has advantages in two things. One, it maintains the chamber. Second, you don't have to use a lot of visco. Here, if you see the second modification, initially we were making the sclerostomy directly under the flaps. So some surgeons told me, why not use the trocar? So the advantage of using the trocar again is the instruments that go in and come out, it's more smoother and the less chances of causing any dialysis in the periphery. And the same trocars can be used if you have to do a complete vitrectomy. So here again, just not pulling out the lens, making sure you remove the vitreous and all the attachment before you remove the lens. So since it was a rigid lens, we'll have to open it up. So that's why the scleral tunnel was done. As you can see here, we also have a slight angulation. So basically it sits like a hammock behind the iris. So that is what prevents it from the rubbing and the pigment dispersions. I always prefer to use the cartridge. And this is another thing is, one surgeon told me in the nasal side, I'm finding it difficult. So why not make a curved instrument? So this, we also came up with a curved instrument for using for the nasal side. So this is what I call as the head-on position right now. If you see in my initial videos, you used to hold the neck. So when you hold the neck, a bulkier portion actually comes out. So what I mean by the head-on position is, when you pull it out, the T bends inwards. So actually the lesser diameter of it, comes out. So it is actually slightly smoother when you're pulling it. So these were, so that we have named this as the head-on position. So this is the trocar assisted way where you have to actually slightly pull the trocar out and then make sure you visualize and see the T out. I think I'm out of time. So this was my journey. And not only that, it is not locally, yes, then we wanted to take it abroad. So these are some of the doctors. This is Dr. Carlo from Philippines, who's thrilled, and this is the entire team that is doing the lenses and very happy with it. And this is the team from Mexico, Alexandro, and they are also started using it and publishing it. Basically, we're just waiting for the next, this thing is the CE license and the other certifications that are needed to take it globally. So that's why the entire time delay is there. So once again, thanks Samresh for having me in this symposium and to talk about my innovation. Thank you.
Thank you, Niven. I think it is always so exciting to see such things coming out of, necessity, like they say is the mother of invention. So you have to, and nobody better than the doctor knows what is needed in times of distress. So continuing with what Niven was showing, the fixation, I'm going to show one or two of how we can in our own clinic image things differently to see what's happening inside the surgical scenario. So we all know that capsular bag is the ideal place for an IOL fixation so far. And it's the ideal case scenario. But more often than not, it does not happen. If you can put a lens in the bag, it's very good because the bag sort of isolates a foreign body from the eye. It sort of covers it up and you don't have a reaction. But sir, there are times when you don't have the luxury of a capsular bag and you want to fix the lens in an awkward position or intrasclerally fix or Gore-Tex fix. So we wanted to understand what actually happens when you're doing this inside the eye, because we don't see it. It's a blind procedure. We decided that we want to see what's going on with either of the fixation techniques, and so we decided to make our own posterior imaging setup. So this is a wet lab setup. It's not a real surgery setup, but it's done on cadaveric eyes. And this is our version of how you would do what is known as a posterior or a Miyake apple viewing system. So what you see here is a broken down 1 FR microscope that's been put upside down, and it has on one side a recording system, which is our HD recording system, and on the other side it has a high-speed camera that records and plays things in super slow motion. Human cadaveric eye is hemi-sectioned and it's mounted on a glass plate. The operating surgeons performs the surgery from the top like we would, and the camera records both from the top and one camera records from the bottom, as somebody would see sitting on the optic nerve head as to what's happening under the iris. And this is the setup that we created. I'm going to show you this case scenario. So this is a patient who had a subluxated, traumatic subluxation, and in our hands, one of the best techniques is to use what is known as a bag fixation. So here we fixated the capsular bag using a CTR and a CONE element. And I want you to see that this is how the eye looks from inside. The transparent structure that you see is the capsular bag, and that's a hydrophobic lens in the eye. And the lens is completely shielded from the ciliary processes, making it a very biocompatible situation. And it maintains the compartmentalization of the anterior and the posterior chamber. And that is why it's a good idea that if you can, to fixate the capsular bag in toto rather than remove the whole thing by a lensectomy and do an intrascleral fixation. Also, if you're able to maintain the bag, you maintain the anterior vitreous phase, which is not only a mechanical barrier, but it's not only a physical barrier, it's also a mechanical barrier, because it prevents your inflammatory mediators from the anterior segment to go back and your diabetic inflammatory mediators from the posterior segment to cause anterior segment inflammation. So if you can preserve the anatomy, nothing like it. But if you have a gross dislocation, like in this case, there is no option but to do a lensectomy and a vitrectomy and then use the sclera to fixate the lens. One of the techniques is a scleral fixated IOL, which has been the gold standard technique. This is how the eye looks in an aphakic mode. There is no bag and the ciliary processes are bare, and so is the posterior iris. We at our hospital use Gore-Tex for fixation. Gore-Tex is an off-label use. This is used for stitching periosteum and pericardium. And the dictum is to fixate the lens 1.5 to 1.7 millimeters behind the limbus, and this is what has been taught. This is what you see when you fix the lens there. You can see that the lens is a large lens, and not only that, you can see that the haptics are rubbing across the ciliary processes and the sutures pass through the ciliary processes. And imagine that in a vascular rich part of the eye, if you're rubbing against the PMMA and having a suture through that, the amount of inflammation it can create inside the eye. We normally would not see it during the surgery. We'll think the lens is well centered. Why is the patient having bouts of inflammation? That's probably because of this. In an intrascleral fixation, which is now caught on, this is the older technique. Notice that once we've intrascleral fixated the lenses are kinked because there's so much manipulation. So if you're using a PMMA haptic, chances are these lenses will lose their memory and they will tilt, unlike the newer versions of lenses which are being used, which is the PVDF haptic, which is more compliant and pliable. So as you can see, all the haptics have lost their memory. Also, like we said, the dictum is to fixate the lens at 1.5 millimeters and look at when we are fixating the lens at 1.5 millimeters. Miyake apple just shows us very clearly you are going straight through the root of ciliary processes more often than not, and this is right pro-inflammatory zone, and this is something that could be avoided. What if you could go a little posterior, maybe just a 0.5 mm? So if you go posterior by 0.5 mm at 2 mm, and we imaged a couple of eyes to see, notice that you've more often than not skipped the ciliary processes and you're in that pars plicatum area. You're not in the area of the ciliary processes, so this is less pro-inflammatory. Something that you could not make out, but this is just what you can see in a Miyake apple in a cadaveric eye. Again, to show you fixation of an IOL using Gore-Tex, 1.5 mm from the limbus, showing it touching the ciliary processes, versus going a little posterior and just saving grace and just being away from the ciliary processes. It's this junction of the pars plana and the pars plicata which is the sweet spot, not only for fixating a lens but also for giving intravitreal injections, because this is the place you want to enter. We thought, why not figure out how we can do it in a real-time scenario? Now, this was a cadaveric eye that taught us in an imaging system. So we learned from publication. So this is what is known as stance palpebral transillumination. We use a near-infrared LED light and a camera, this is a security camera with a +10 diopter lens. So you hold the security camera because it has infrared imaging, and you put that LED, and what happens, lo and behold, your pars plicata and pars plana area lights up. This is the area that you are interested in. This will light up the moment you put an LED over here and use that camera. Pretty rudimentary, but you can do it on your own imaging system, will cost you nothing to do. It's been done before. It's been done for transillumination photography in intraocular tumors, and it's been done in glaucoma using near infrared spectrum, but it's never really caught on because this was slit lamp guided. So we decided to simplify the system. So suddenly it makes the whole process image guided. It makes your intravitreal injections image guided, it makes your lens fixation image guided, and thereby it makes the whole thing easier. So again, I said, if you look at fixation techniques, there are so many ways of fixating, and what is good and what is not a judgment of what is easy, what you can do in the clinic, but what happens inside the eye when you do it. And I'm going to show you one thing that I did long back. I'm not going to waste time on this, but I wanted to show you. Long back, if the sides are playing, yeah. Long back, we did a very interesting study, because this we did on posterior segment illumination, is we used high-speed cameras to capture what's happening during cataract surgery. You would think, what is there to see? You know, in a cataract surgery, it's a routine surgery, and there's nothing great about phaco. So we set up this thing. This is the same camera that I was showing you. That time we picked it up from a company called Allied Vision Technologies in Singapore. We mounted it on an operating microscope, and we recorded what's happening. The good part is your iPhone now has 200 frames per second, so you can really do high-speed photography with your iPhone, and you can just mount it on a side scope. You really don't need to have this assembly. I'm just going to move ahead in the interest of time to show you that when you do a quadrant removal, efficient phacoemulsification is one where the fluidics are happening and the material is going in. But if you occlude or you core through a nuclear material, what we see as lens milk, and we've all seen lens milk, is basically emulsification that's happening, but because the aspiration is blocked, you are heating up the phaco probe. So beautifully visible here, and that is what causes wound site thermal injuries and inflammations in the eye. On the other hand, the simple technique that we did was tilt the probe, and we made sure that we do not have 100% occlusion. So there is a flow of fluid always happening from the side. Suppose it doesn't happen, you just give it a nudge, but don't have the lens milk appear. The entire nuclear material so beautifully rotates because of fluidics without causing any wound burns, and is coming out of the eye. This is obviously it's too slow for comfort, but if you look at it this way, efficient phacoemulsification means you don't waste your energy inside the eye, which is what high-speed imaging taught us at that point in time. So finally ending up my talk is, when you realize that there is an issue in the eye, and you realize there is an issue or there's something that you want to do, think out of the box. I've learned it from my mentors, Dr. Vasavada, Dr. Sri Ganesh, that is sitting over here. You know that it's always a good idea to look at things from a bird's eye view from outside. What the industry teaches is one thing, but what you can bring out may be totally different and totally new and helpful to the surgeons. Thank you. So next up we have Dr. Sri Ganesh, who's going to walk us through his series of innovations that he has, all of which have extreme clinical relevance in our day-to-day practice.
There's a connector, right? Okay. Good afternoon, everybody, and thank you, Samresh, for inviting me to this very interesting session on innovations. So let's look at the cycle of innovation. So it's not a simple cycle. First is to identify the problem. Only when there is a problem, then you look at solutions. So that forms the research question. Then you get an idea as to how you can solve this problem. And you have to define its need, understand the opportunities which are there. Then you create or you make the invention. That is, you design, develop, and test whether it works. And then comes the implementation phase, which is basically proof of concept and a risk analysis. What are the complications or what are the problems that this device or technique can present. And then you go into testing the prototype and clinical trials, where you need to have permission, you need to take the approvals, and then you look at intellectual property, patents, funding, and then once you commercialize it, then only an idea gets converted to an innovation. So let me show you a few of my innovation. First is what we call the swivel haptic IOL. So I was thinking about capsulotomy fixated IOLs. I was riding my bike, and then I stopped and put the side stand, and then I had a eureka moment. Why not have 2 extra swivel haptics on the IOL, which can swivel out and capture the capsulotomy? So we made this. The first prototype had PMMA haptics, swivel haptics, and that was breaking. So then we again looked at different material. Now we have a proprietary material. You can see the white that does not break easily. So once you inject the lens in the bag, then you rotate the swivels over the anterior capsule, and it captures the capsulotomy. This is a toric lens, so you can see the markings. So with this, it is easier to remove the viscoelastic from under the lens compared to the other capsulotomy fixated lenses, and you don't need a femto. So the IOL is stable, no rotation for toric lenses. You can see intended axis is 104 degrees, and post-op refraction is perfect. Of course, we have got worldwide patents, and we are looking at commercializing it. The problem is it is labor intensive. So we are looking at other designs where it can be easy to manufacture. The other invention was the Ganesh toric IOL marker, which is available with Epsilon. So the problem was in small pupils. When you put a toric IOL, it's very difficult to know the position, because the peripheral marks, you can't see it. You have to retract with your with a retractor or a dialer. There's increased release of pigments, increased prostaglandins, cystoid macular edema, post-op uveitis, IOP spikes, etc. So these are all problems with manipulating the iris. So then I was looking at the problem, and then after my OT, then I went to the gym, and then I was working out with barbells, and then I just placed the barbells on a bench. And then once I lifted the barbell, I saw that there was a mark on the bench which stayed for some time. So I this was a eureka moment. Why not make a temporary mark on the lens? So this is what I made, the toric marker. So it's got windows to align the peripheral marks, and then you can make the temporary mark by indentation, and so that even in a small pupil you can very easily align it. So this is the toric marker. Those are the windows through which you see the peripheral dots, and you can see you get a mark there. And then you load the lens in, you inject it. The mark stays for about 2 minutes. So that is enough for you to position, and even if the pupil is small, you can't see the peripheral marks. You know that it's exactly on axis. You remove the viscoelastic, settled everything, it's still there, and it disappears in about 2 to 5 minutes. Whether it affects the quality of the lens, we did the OSI with the scatter. We looked at also the higher order abrasions, whether it induces any abrasions, but there were none. And you can't even make out there's no scratch on the lens. So that's a small, so without handling the iris, you can align. So necessity is the mother of invention. So whenever there's a problem, you start thinking, how can I solve the problem? And then you're able to. The other problem was, the other invention was a cystosome maker. So our OT boys, the OT assistants were using the needle holder to bend the needle. And the needle holders also used to get damaged. And it was not standard. Depending upon the assistant, sometimes you used to get good cystotomes, otherwise it was not. So I decided, why not have a standardization? So I made this cystotome maker, which is like a cutting plier, and I'll show you how it works. This is also available with Epsilon. So that is how it is. It's got a small nub there, which basically bends the tip of the needle, and it's got a depression which holds the hub of the needle. So you take the 26 gauge needle from BD, you place it there in the hub. So the length is exact. So when you press the the plier, it bends the tip of the needle exactly. So you get that 0.5 mm bend at 90 degrees. So you can see that as you bend it, it is bent. Okay, and after that you just press, so you get that exact angulation. And this basically is typical. The measurements correspond typically to the cystitome made by Alcon, for which they charge $20 to get. So this is standardization, and when you have standardization, then it helps your surgery. Irrespective of the assistant, you get perfect cystotomes all the time, and your needle holders are not damaged. So this is, and once you have a good cystitome, then you can get a very nice capsulorhexis. And otherwise, sometimes the bend is too small or too large, and once you have the standardization, then it becomes easy. So that's a small innovation. It is available with Epsilon, and I think quite a few people, we use it regularly in our OT. Of course, I now use the femto, but the other surgeons do. Then the other problem, we have a fellowship program, and then we have complications where they have PCR during phaco. So during phaco, if you have a PCR, there's a very high risk of nucleus drop. So then we thought we'll make a safety net device, which is a temporary rescue device, and this is how it works. There's a PCR during phaco, so you can see that the large nucleus piece is there. So if you emulsify it, there's a high risk that you can have droppings in the vitreous. So you make the side ports for iris hooks. Then this is like a grate. So we put it in, it's made of hydrophilic material. You can put it in with the injector. You place it over the iris, and then you use iris hooks to kind of hold it. Now we have again the second prototype made. You don't need the iris hooks. You have extrusions which you can pull out, and it is self-retaining. So this is, you can put 3 or 4 iris hooks. So now it is supported, and there is no chance that the nucleus can drop into the vitreous, and you can safely emulsify it and remove it. You don't have to extend the incision. Once that is done, then you can very easily remove the iris hooks, pull out this device. You just hold it to the forceps, pull it out, then you can do your vitrectomy and cortical cleanup. Here the rhexis is intact, so we do a vitrectomy, clear everything, and put a 3-piece IOL. So this is like a rescue device which you can use. Then the other innovations, lenticuloschisis, the no dissection technique. Now we are publishing, we did what is known as a parameter study, and we have found the best parameters. Last ASCRS also, we got an award for the high impact Pearl video for this technique, where you can very easily remove. I'm not showing it. And of course, a lot of SMILE instruments which we have done, and tissue implantation, or what we call FILI, where we implant lenticules for hyperopia and for keratoconus. That also works very well. And we also first defined intraop manual cyclotorsion compensation for myopic astigmatism in patients with undergoing SMILE, because the Visumax 500 did not have a cyclotorsion compensation. That's published again in the JRS. And viscochop is another technique with a femto, where you can actually use viscoelastic and hydraulic pressure to separate the fragments. So basically it's a thought process. As you keep thinking, you will find solutions. So for research, you don't need a lab, or you don't need very high-tech stuff. I always say research is a frame of mind, and you will always have you should have a problem-solving mind, and you can find new solutions. Some of them are very innovative. Some of them can be commercialized, and you can also make some good money if it is successful, like Nivian showed his device. I don't know how much money you have made out of it, but that's the end goal. Thank you very much.
I have just one or two questions. One is, you really want, if you do, you need to put ink in that marker, the toric marker, or you can just indent?
You need not put ink. If you put ink, then it's clearer. If you just indent also, just by the reflex of the microscope, you can see it. So you need not put ink.
That fear of ink is going to go away.
Fear of ink, because that is a very blunt blade. So when you press on the lens, it leaves a mark.
Last week I had a small pupil, and I was thinking of you, and I should have ordered this. It would have been.
This is available with Epsilon, so it's very easy to do.
And the second is, you showed a very nice cystitome bender. And Nivian gave a business idea. He said, "I'll put my nurse to make and sell." You know, that's what he was saying. Yeah, no, but the thing is the needle calibrated? Are all needles the same or?
These are the BD needles, 26 gauge. They're all the same, half
So
inch.
there's no needle difference that
No,
comes
there's no
up.
needle difference. That is pretty standardized. So the needle is the same. So you get exactly the same dimensions. But if you're using a 30 gauge or some other company, then you need to, I think they have different models, but originally this was done for the BD 26 gauge needle.
Any questions from the audience? Dr. Jayesh?
It can be very cheap. You need not. It's available with, but it's not commercialized as yet, because we have got the second model in which you don't need the iris hooks. The extrusions, you can just pull it out. It's got like a, again like a T, which sits at the, so it locks in. It's not yet available. The first prototype is there. A few of the surgeons have used it, but the second prototype, we're still testing it and then looking at a few more modifications, then it'll be available. I mean, these are things that you want use on a large scale. It's occasionally you have a PCR during phaco, maybe 1 in 1,000 or something like that, and when you have this device, it saves you. So it's good to have in the OR. But commercially, it doesn't make sense for the company or for the inventor. But there are some things that will make commercial sense where you can earn some money. Lens, but the thing is, when you put the lens in, you can't remove the expand the lens, and then doing a thorough, proper vitrectomy, clearing the cortex may become a little difficult. And the lens is moving, it's in the angle, the haptics are in the angle, so you'll get some amount of angle damage, trabeculitis, hyphema, so these are all issues, so this is prevented by this. Yeah. This is because it's got a, it's like a ball, so you're away from the endothelium also.
So my talk doesn't have any commercial interest, and it cannot be done any commercialization. So anyway, I thought few basic modifications which have helped me should help many of the people. So just I'm trying to share with you all. So this is our post-polar cataract, we all know now, and what is the fundamental reason for the weak PC to give way during phaco in these polar cataracts? I think this is one of the questions we always keep asking, and the compromise in the AC equilibrium that happens, this weak PC cannot take in any of these things. So whenever we have a sudden deepening or sudden shallowing, both can cause the trampoline of the posterior capsule and it ruptures. Solution is we always keep replenishing the OVD into the eye before pulling out the irrigation device, and that has been done. But the problem is many of the younger surgeons, less experienced surgeons, find it a little bit challenging for the lesser experienced or lesser skilled surgeon. So that is one thing, and second thing would be the amount to be injected is not controlled. The second step, what step of the surgery is more likely to induce a posterior capsular tear in these polar cataracts? Most likely it is always going to be the subincisional lens matter, the softer epinucleus or the lens matter. That is the stage. At this stage, because we have a round rexus, that is where we get this posterior capsular tear happening. So I was just thinking, what do we have answers to these two questions which can address? I think the first, the basic goal would be to maintain the chamber equilibrium at every step of the surgery. So you are not consciously involved in big focus and try to push back the OVD and all. So I think just went back to a very old forgotten device that is just the AC maintainer. It was used way back by Blumenthal for ECC actually, many years back. I thought this could do the job because the thing. And second one would be just instead of the round rexus, why can't we use an oval rexus, which was again proposed by Dr. Kiranjit Singh way back in 2011. So these are the two modifications which I hope that they could help us to deal with these problems and make it more simpler for majority of the surgeons. Now, what should be the size of the oval rexus? That is a challenge because we want this to be around 6.5 millimeter and this has to be around 4.5 millimeter. That should be the ideal one because at least one end we have a complete overlap of the optic. And then this is the 22 gauge AC maintainer which you have used. This is inserted after doing the rexus. The most critical factor is we want to maintain the bottle height of 50 centimeters at both the phaco irrigation as well as this. And other parameters, because we are maintaining the chamber always, you have to have a low flow rate and vacuum to compensate for this. Obviously, no hydrodissection, no nucleus rotation, the standard protocol you have to follow. And in situations where we are able to do hydrodelineation, we would go ahead and do the inside-out hydrodelineation as has been prescribed by Dr. Vasavda. It is very helpful. And see, when the instruments come out, you don't have to go in and refill the chamber. As come out, the chamber is still flat, formed. No tension about, keeping on reforming the chamber. And now I'm going to do the hydrodelineation. And then we have this is a very young patient, very soft cataract. And now, see what happens, the distal part of the epinucleus has come out now. We have got the subincisional part. Now, because we have got better access because of the oval rhexis, we are able to maneuver the subincisional part of the nucleus, epinucleus, and it is very easily stripped off. So what basically, by stripping the cortex, we're displacing the epinucleus into the center part. This obviously cannot be aspirated by the cortex. You just try to displace it. And during all these maneuvers, the chamber is always maintained because you're not compromising the equilibrium at any stage. Now, because the central part is not displaced, the subincial, then you go ahead with your phaco probe to a 2.2 incision, and then you aspirate it out. And again, you come out, no problem with the chamber. You just maintain it as usual. Then only during IOL implantation of the antechamber maintainer, and then maneuver the lens into the bag. Only thing is, the critical factor is you have to have overlap at least in the two edges of the rhexis. That is what would be the critical thing. The argument here would be, we have learned so difficulty to make a round rhexis, now we want to do an oval rhexis and this thing. So for that, I think it's not so difficult at all, it's easy. But only to have a template so that we have the exact size. Now we are trying to ensure we designed the marker, the corneal marker, which I'm going to show you just now. So it will just ensure that we have a template by which we can do this. Now, this is again a situation where the lens is slightly denser here. It's not like the younger patient which we had. In these situations, what I'm doing now is I'm doing the sideways sculpting or the cross sculpting. So remember, we can't rotate the nucleus. We can't rotate the nucleus now, and you just do this sideways sculpting, and you are able to divide the nucleus without inducing any stress or any maneuver which can be detrimental. You have created a cross by doing this cross sculpting, and you're able to gently divide this nucleus into the 4 fragments and then pull them out. And again, you're left with the subincisional part of it. Now, because we've got a better access, mobilizing this will be easier. Again, you come out, you don't have to put in OVD again, and you are good to go. So this has been, it has made life simpler even for the younger surgeons. You don't have to be constantly bothered about maintaining the chamber always, because that is quite stressful. And then you go ahead and do the implantation. So let me just go in and show you what would happen if the posterior capsule is already open. So this is how the eye would look like in this case. Now this is a patient where you have a pre-existing posterior capsule defect. Even in these situations, even with the AC maintainer on, there is no worry that is going to cause anterior rupture or vitreous prolapse. The point here is the fluctuation in the chamber is more detrimental or for inducing an anterior rupture rather than a constant. So don't imagine that this fluid will be always gushing in so much. The common argument is AC maintainer is on, it goes in, hydrates the vitreous, more vitreous will come out. No, that argument is because the anteriohyaloid enough is still firm enough. Only the fluctuation is the one which is going to cause a problem. The moment you have fluctuation, the tendency to rupture the anteriohyaloid is more. When the anteriohyaloid ruptures, then we have all the sequelae of vitreous hydration and all those things. So this is a case where we have a pre-existing breach in the posterior capsule in a young boy, and it is caught in this thing. And even in this case, when we knew that it is there, we have still used an NC. There is no drop nucleus, nothing will happen. So don't have to be so phobic about this. And the conclusion is this 3-point modification which we are using has been very, very helpful. The oval rhexis, anterior chamber maintainer, and the low infusion pressure. The critical factor is the low infusion pressure. Majority of people feel that when the PC is open and you have got fluid going in, it is going to blow out the posterior capsule, enlarge it, rupture the anteriohyaloid, cause vitreous hydration. It won't happen unless and until the infusion pressure is too high. That is the message which I'm telling. So the argument would be the nucleus will drop down, nothing will happen. So this is somewhat some of a device which we have, marker which we have created, which would help us to form some sort of a template. This is how it is, and it's just like this. You just calculated this thing, and so this is the message here, that this is what I have been working on, and that really served me well. So 3 things, Volrex's antechamber maintainer and low infusion pressure. Thank you, Sambaresh, for the opportunity.
Thanks a lot, sir. And like always, the videos are so stunning. I'm sure that's why we see more things. Otherwise, during my surgery, I don't see half the things there. Also, like you had shown previously, the importance of understanding your machine. A lot of the times, a lot of people will buy machines, but we'll put the industry parameters and we'll working on that 90 bottle height, 100 bottle height, and earlier they used to put fish pump for infusion, and that's why all this.
The most surprising aspect is when they buy the machine and the company person comes and sits on setting, phaco 1, phaco 2, phaco 3. Next 20 years it will be the same.
Exactly. Exactly.
So that is one thing which you can forget about phaco 1, phaco 2, phaco 3. You should know your machine well. There's no point in having a Ferrari as well if you don't know how it works.
Exactly.
It doesn't make the job.
Exactly. I think that was very beautifully put up, sir. Any questions from the audience for Dr. Deepak?
Yeah. Yes, sir. Yeah. Sir, the shorter edges, they are the one which can help to optic. No, 4.5 what we have, if you've done a vitrectomy properly and then put it, usually it doesn't pop out. So the sizing of the side 4.5 is critical. That is what is the one which saves you in such situation. This is 6.5 and this is 4.5. So if it becomes 5 or 5.5, then it pops out. That's the critical part of it.
Thank you, sir. Thanks a lot. So next up, we have a keynote talk from Mr. Shaurav Das, who heads the product development at Alcon Laboratories. And I have been associated with Shaurav for almost a decade and a half. And every time I've met him, I've learned a thing or two on how to catch the pulse of the patients and how to make your product show out better and how to upgrade your services. And I owe a lot of my knowledge to Shaurav. So Shaurav, it's my pleasure to welcome you for this talk.
Thank you, Dr. Samresh. And, great discussions this evening. And, can we have the slides, please? So great innovation, of course, comes at some price for that matter. And, what I'm going to do in the next 15 minutes is, just give you some ideas, some strategies through which, you can have these couple of upgrades that can take place in your clinic where you can charge a patient. And what are the simple ways that you can do so? So these are 5 different reasons why you should be upgrading your technology per se. One of course, you can make a differentiation. We just had Dr. Ganesh, Sri Ganesh, and every other stalwarts, who feel that, these are the important benchmarks that you can talk about when differentiating. Next up is, when there's a surgeon differentiation, what really happens is surgeon and staff per se are super excited when there are discussions where there's a new technology which is there. But more so, I think the most important thing is that your profit margin also increases technically as you move forward. Any of these technologies can be looked forward for upgrade. It could be a LASIK technology, it could be IOLs, it could be any of the services that you want to offer. But most important thing is that how self-convinced are you about this product or any technology or any service that you're trying to talk about. Unless you are convinced about this technology, it will never show up in your body language as you move forward. Hence, the journey is from I wish you had patients with ABC versus every clinically suitable patient should actually have this technology. So here are a couple of 12 strategies, a dozen of them, which I wanted to share with you guys. One is, when you want to upgrade into a particular technology, integrate pre-education materials into your practice. I think this is something that is very less in India, but I think sending patients a pre-read material is something that really helps them clear the doubts, and then they come prepared with what to talk about. Second is discussion on the visual needs. So here is a simple technique which you can use in your practice, wherein a lifestyle questionnaire, where patient is actually ticking up, what are the different things that he or she feels, whether it's cataract or LASIK surgery, that he or she feels he should be doing or he should be expecting after the surgeries. And when the patient is actually ticking this off. He's actually thinking about it. Oh, really? I can get rid of glasses, or my dad can get rid of glasses after cataract surgery? Oh, wow. So this really helps in the discussion and that upgrade that you're planning to have with him. And these days, you have patients who have very weird reasons of getting rid of glasses, right? From somebody that I know who said that who just wants to get rid of glasses because he was an avid cards player, a rummy player, and he says that when I wear glasses, my opponent has an opportunity to cheat on me because he can see the reflection. As simple as that. Reason to somebody who, a Gen Z who said that, I want to get rid of glasses because these days most of the movies are on 3D, and 3D and glasses doesn't really work about. So never underestimate when you see a patient coming and thinking, isko chashme ki kya zarurat padegi? Why does he want to get rid of glasses? That's really not a great thing to do. Wisely invest on your chair time. I think chair time is the most scarce commodity and a very precious commodity that you have in your practice today. So you don't want to end up investing disproportionately. So there is a certain amount of discussion which you should leave it for your counselors, but you should be doing the important part of it. So the mundane part has to be with the So when you enter into the discussion with your patient, be prepared with all the details so that you have the lifestyle questionnaire ready, and then you have a recommendation ready, so you can directly start off and make those important recommendations. Never feel shy in recommending a particular technology. Recommendation is not selling. Recommendation is telling that, had I been in your position, I would have done this for my dad or for myself. So recommendation, if you practice, it doesn't really sound selling. So this is a very important step when you want to upgrade into any technology in your practice. Invest in good patient counselors. Something which you want to invest next after a phaco machine and a microscope is something which is investing in a good counselor. And a good counselor will do a ton of job for you. Couple of things that you should be looking at when you invest in a counselor. Normally, practices that I've seen and I've worked with, they tend to just move, let's say, a front desk person, since she was working for 7-8 years, into a counselor role. That might or might not be always a great fit. Counselors are somebody who are good listeners, who are great in visual discussions and so on and so forth, and are good in communication. Seniority doesn't have to be a part of that attributes that you're trying to look forward for. The general attribute when you want to upgrade and this is for any consumer technology, and I'm a marketer by qualification, so is that what is the value that you're trying to give to your patients in this case, versus at what price point. And if you see the value, you have to show the value higher than the price point, and then the upgrade strategy really happens. And that is where you want to talk about. So that delta cannot be the same. Itna value hai, itna price hai, then it is market. The price has to appear quite smaller. And how do you do that? When you preach benefits and not the features. No patient is interested in knowing how many rings the lenses have and what technology. You want to talk about that for most of your daily activities, for near and intermediate distance, you don't need glasses. Those discussions really pretty much help. Use visual tools, these days. I think visual tools, because the decision makers, as we all know, primarily are the caregivers, the sons and daughters in cataract case, decide for their parents. So instead of just saying everything will be fine, using visual tools is a good idea to just reiterate the conversation and make things much more easier. In terms of LASIK, I think addressing the fear and anxiety, I think use, and I think most of the counselors can be taught about, what are the common phrases that they should be using and what are the things that should be avoided. Is LASIK painful? 99% of the patients still that didn't realize, conversations like these and, for any of these discussions. I'm a marketer, as I just said, but I in all honesty, I said that nothing can beat trust technology. So in this particular case, testimonial, one patient sharing testimonial or feedback to another patient, no marketing material can beat that per se. I think making a good patient testimonial video, a home video, is good enough. It's just identifying and addressing, recognizing one person in a practice whose job is just to take a testimonial video on a mobile phone when that wow factor and the wow moment is coming. Talking about wow, I think every patient who comes to your place and who has upgraded into advanced technology is a potential ambassador for you. Hence, you should try to make sure that a post-operative discussion happens, a counseling happens, which essentially means how you create the wow factor in them. When you create a wow factor in the patient, he or she tends to become your ambassador and will go from one place to other, talking about your practice and talking about the technology. The follow-up strategies. I think it's super important that these days, you just to check up and what is the, so patient inquires, discusses, goes back. And there has to be a definite nice follow-up strategy from your counselor standpoint. It doesn't have to sound very pushy, but somebody needs to follow up sequentially within 48 to 72 hours. And if there is a dropout, what are the reasons of dropout? It cannot be because a question was unaddressed in your practice. Staff education in totality, from check-in to check-out, the patient experience is super important. And because the patient experience is important, it's important that every staff member in your practice says the same language. And that's why occasional, so what normally do is you normally have a training for sure, but you selectively choose patients, like OT staff, you don't need to do this, ABCD. Staff training has to be in totality so that whenever a patient or caregivers interacts with any of the patients, any of your staff members, they say the common language. They say motivation doesn't last. Well, so does bathing, but we still recommend it daily. Hence, I think team-based incentive programs, if it works best in your school of thoughts, for everybody, let's say a team, as a team, if you achieve an upgrade of a particular technology in your practice or a service, as a team, it doesn't have to be a personal incentive. You, let's say, go out for a lunch, or let's say you gain something out of it. I think this really works, and we all work for motivation, and why shouldn't your staff work for a motivating system? And when it comes to addressing the financial barriers, I think a couple of things on how you can make your price, how you can price your technologies is that, a general recommendation is that you be moderately priced. You do not, for any technology, don't be too low priced, don't be very high priced also. Use cross-selling techniques, to upgrade your using. And have a bridge segment. A bridge segment is a segment that you want a patient to aspire, and in between you keep a segment which says that if not this, while you have reached up till here, why don't you actually upgrade to the latest technology which is there? And I'll give an example of what cross-selling means is, what you see in the first is an upsell. When you have, let's say, a margarita pizza versus a cheese burst pizza, that's called an upsell. But what's a cross-selling is when you've already opted for a cheese burst pizza, and then you get everything in totality, which is Coke, fries, and cola. You get everything together, that's an upgrade. And when you do a cross-sell, you get a discount. So which means that if the patient chooses, and this is what patients are more likely to get in, when a patient chooses, let's say, a flax, a femtosecond with a monofocal lens, they get an X% discount, versus, let's say, with bladeless LASIK, it gets some additional discount. And lastly, I think it's important that you track your progress in terms of the metrics. What were the dropouts last year? I think this is something that most of the practices forget. I think you should spend once in a quarter thinking about and analyzing your data so that you can reinvest and double invest on places which you feel. For example, referrals are giving you more benefits. You would want to reinvest in places of that, and so on and so forth. In summary, I think what I would say that there's a high grade momentum in India from an advanced technology standpoint. You would be there has been a constant 8.2 CAGR growth, and that's predicted by 2031. That's for an upgrade technology in specific eye care, close to 100 million in the days to come. And there is a heightened awareness because of medical tourism, and we see digital marketing and so on and so forth. I think now is the right time where you should, any technology that you want to upgrade and introduce into your practice, I think this is the right time where you should be doing that, and because the situations are pretty favorable, and there's a lot of opportunity in the days to come. So think about it, and thank you so much for your time.
Thank you, sir. I think there was a lot of experience talking there and very precise points. We all agree, we as ophthalmologists spend time and we're good at clinical practice, but now today it has come to a point that all these things are really important, and I think this was a very nice and eye-opener thing, especially the last slide. Any questions from the audience regarding anything? So I think then
Cool.
that will be
Thank
it.
you very much.
Thank you. So we'll be closing the session. I think
Thanks.
Samresh had to leave early for another session.
Yeah.
So thank you for being with us. Thank you
so much.